Hi, everyone. Welcome to Dean's Chat, where we discuss all things podiatric medicine. My name is Dr. Jeffrey Jensen. I'm the Dean at the Arizona College of Podiatric Medicine and the host for the Dean's Chat podcast. I'm joined today by my co-host, Dr. Johanna Richey. Thanks for joining me, Jo.
Thanks so much for having me.
Oh, you're welcome. Today's a special day for Dr. Richey and myself as we get to interview a pioneer in podiatric surgery and podiatric surgical education. Welcome to Dean's Chat, Dr. John Ruch.
Good afternoon, ladies and gentlemen. I'm really excited to be here. Thank you so much for having me.
Oh, you're welcome. And Dr. Ruch, we're pretty informal here on Dean's Chat, so if it's okay with you, let's just go with first names, John, Joe, and Jeff.
Very good.
Sounds good. Joe, if you would like to take it from here.
Yeah, I would love to. So thank you so much, Dr. Ruch, for coming on today. It's been a pleasure to kind of get to know you over the last year or so. And we just wanted to start with kind of a brief introduction. Your career is cataloged in probably a textbook worth of information, but I wanted to highlight just a few things for the audience to know about you. So Dr. Ruch graduated from podiatry school in 1973 from the California College of Podiatric Medicine. He went on to do his residency, the first year of surgical residency with Northlake Community Hospital, which was customary at the time, and then continued with additional training, which was not as customary at the time, for an additional 2 years, training under the direction of Dr. Dalton McGlamry in Tucker, Georgia. You also attended the AO basic and advanced courses in Davos, Switzerland, and was one of the first podiatrists to do that in the late 1970s and brought those techniques back to the United States. You performed one of the first subtalar joint fusions using those AO techniques in, I think, 1976. And you're currently a professor at Emory University School of Medicine. You're attending faculty for the Emory Podiatric Medicine and Surgery Residency Program in Decatur, Georgia. And you've been a prominent contributing member to the Podiatry Institute. That's how I first met you years ago when I was a resident going through the AO courses, and then recently again being reintroduced to you. You're also a founding co-chair of the original AO courses from 1993 to 2013, and then followed with being the co-director of the AAFAO Podiatry Internal Fixation course for the following 5 years. And you're a mentor to many people, but that's really where I'd like to start. Your father was a podiatrist, and we would love to hear a little bit more information about what that was like growing up in a podiatry household.
Well, it was great. And again, as I've mentioned, my dad is still with us, so I still have the pleasure of seeing him and really even talking about our profession and where it has been and where it is today. And certainly he's just always amazed at what he sees from our profession today. So it's been a big change. 1950 to the current, so that's 70 plus years that he's been involved with it, and obviously I grew up with it. I can remember as a kid growing up and following my dad around and seeing what he did, and I always remember that's all I ever wanted to be, was a podiatrist. I grew up and saw what my dad was doing for people that, if you will, the general medical community wasn't able to do. And it was just very rewarding to see the wellness that he brought to his patients. And so that was always my goal. You bet. Absolutely.
And seeing that kind of evolution of a profession, if you will, is such a remarkable opportunity. And I think you're one of few that has really been able to see that transition over time. I know you've also talked about some other mentors in your past. Can you talk about some of the most notable ones for you and kind of the things that maybe each one contributed to your thought process or your approach?
Sure. Well, again, my dad started practice in 1950, and he was really right on the cusp of podiatry starting to do surgery. Up until the 50s, the profession, as you know, was known as chiropody, and then it changed the name to podiatry and entered the surgical era, really under the direction of Earl Kaplan. That's certainly one of the historic founders of podiatric surgery. Dalton McGlamry came along not too long after that, and really established the first 3-year residency program in the profession, and it really remained that for many years. But that was, again, back in the late 60s, early 70s. So I always remember going through school, obviously wanting to pursue a surgical career. And Dr. Kaplan and Dr. McGlamry were people that I followed, if you will, to how the profession progressed in surgery. So when I went to school, I went to the California College, was considered one of the more progressive schools at that time. And the real draw there was biomechanics. The education of biomechanics was relatively new to the profession in that format with Bill Ryan, John Root, John Weed, all the classic people, Thomas Sgarlato, Roy Kroecker, et cetera. And they were just tremendous teachers and educators and researchers, and they really brought in this new science to our profession at that time. So that was a real draw to the California College. And even back then, I remember people, I'm sure you know the names of Josh Gerbert and Guido Laporta. They were residents when I was a student out there, and so I'm that old, if you will. So we've certainly been colleagues for many, many years, and I've obviously appreciated everything that those guys have done.
Yeah.
At that time, when I graduated, there really weren't a lot of residency programs. Most of them, the few that were out there, were 1-year programs, and again, there was only one 3-year program. So I wanted that 3 years of residency, and there was only one resident taken at that time. So there was the competition, if you will, for that one slot was pretty big. Interestingly, Dr. McGlamry Sr. Had a 2nd and 3rd year program. He did not have a 1st year program. So you had to do your 1st year someplace else. So I was fortunate enough to get the elite surgical program in Chicago under Lowell Weil Sr. and Dr. Smith, Smith and Weil, if you will, the famous names of the duo back in those days. And so that was quite an experience. That was 12 months of podiatric surgery from 7 o'clock in the morning until 7 o'clock at night, 5-6 days a week. So you really got a lot of experience and a lot of practice in surgery at that time. And then I was fortunate enough to get the program down in Tucker, Georgia. At that time, it was Doctor's Hospital, and Dr. McGlamry was the director of the program. And so we had basically 2 residents. You had a senior resident and a junior resident. My senior resident was Don Green. So if you know him, Don has had a tremendous career in our profession. He just recently retired. He did the program, ultimately went to the Pennsylvania College, where he was a director of the surgery department for 20 plus years, and then went on out to San Diego, where he was associated with, still is, the Scripps program in San Diego. So some real names in our profession, very, very tremendous surgeons and educators as well. So I've got to rub elbows with a lot of these guys over that period of time.
That's incredible, John. So going back to your California days, I also went to the California school, and Dr. Weed was one of my professors in the biomechanics department. And I always thought it was just a special gift to go to the California school, take that biomechanics background, and then I went to Kern Hospital. I never got the chance. Wow. I never worked with Earl Kaplan, but I met him.
Yeah, and you knew his son then, right?
Oh, yes. I worked with Gary and Dale and Randy, that whole gang up at Kern. Right. You know, I have a question for you, talking about early 70s, because the Kern Hospital, it went from Civic, which was like a house, to Kern Hospital as a structure in, I think it was 1973. Could you talk more about the collaboration between the McGlamry group and the Kern group? I think this is some great history.
Well, I don't know that I can help you much there, other than knowing that Earl Kaplan and Dalton McGlamry certainly collaborated with each other. But at the time that I was a resident, there was not a collaboration between the two groups.
Okay.
Directly or specifically.
Okay, that makes sense.
My dad, go back to my dad, he did the program at Civic. So, if you remember when they started, Earl Kaplan, I don't know if it was every weekend or it was one weekend a month, but doctors would come from all over the country and mentor there at the Civic Hospital or the house, if you will.
Oh my gosh, I've heard so many stories over the years of the residents reusing gloves and sterilizing them, and oh my gosh, just crazy stuff. Oh, that's so good. That's great history. Your father was at Civic. No kidding.
Yes.
Oh my gosh, that's a great story. All right, thank you. I just wanted to make a comment on that, and as a small world has it, Don Green did post-op care for my mom when she had her bunions done. So it's just a small world, John.
It is. We're all very closely related.
Oh yes, we are.
So then I have another question for you, John. Kind of going back to your early career, you had talked about an orthopedist that you also mentored with, Dr. Seacrest, I believe.
Yeah.
What was how did you meet him, and what was that influence like?
Well, I was just started my residency at Doctors Hospital in Tucker, Georgia, and Don Seacrest was a new orthopedic surgeon. He had just started practice and had come and he had some AO training. He attended the AO courses in Davos, Switzerland. So he was utilizing screws and plates. And certainly I was very fortunate to work with him on all kinds of surgery. But lower extremity surgery, obviously ankle fractures was the primary thing. So I early on was exposed to the AO technique and concepts, even as a resident back in that time. And so by working with him and always looking to try to do things better, I started to look at the procedures that we were doing in the podiatry training program. And kind of one of the primary procedures was rear foot fusions, subtalar, triple arthrodesis, things of that nature. And back when I was a resident, in that old story, we would resect the joints, we'd pack in some bone graft, we might throw a couple large diamond pins or something across the joint and put them in a cast. And that was a standard triple. I can remember always being intrigued, even as a student in school, about this new concept of compression with bone. And I don't know if you know the name Howard Zlotoff, but Howard he and I were students together, and he developed the compression device, and it was called an osteoclasp. And it was a Z-bridge staple that you stretched out, put down in two holes, and then as it closed, it created compression. So that was really an exciting thing to see something like that applied to foot surgery.
Yeah.
So we started looking at applying this compression, and it didn't take too much to figure out. We could drive a screw from the talus into the calcaneus and compress through the subtalar joint and other joints as well. So the first fusion procedure that I performed was with Dr. Seacrest, again in 1976, and we did a subtalar fusion and put in one single 6.5 cancel screw. And I actually still have those slides in my lecture and carry it around with me forever. So I finished my residency in 76 and then went into practice. I actually went into my practice with my dad in Illinois. And he had been the director of a residency program there for quite a number of years. And my goal was to go back and take over that residency program. And unfortunately, the hospital shut down the program while I was in residency.
Oh, no.
So when I came back to Illinois and went into practice with my dad, it was kind of an unfertile environment for education. And I guess, had a passion for teaching and working with people. And I ultimately went back to Georgia and became involved with the program. And I became actually the director of the residency program there shortly after. But we really started to identify, try to apply the use of screws primarily to literally any of the procedures that we were doing in the foot, from bunion surgery to fusions, ankle fractures, things of that nature. So Don Seacrest really was the fellow that opened the door to me for this science, and then I pursued it as I continued my career. Definitely.
And how did you find out about the Switzerland courses? Was it through him or?
Yes. He had taken the courses. So we went in 1978, I think.
Yeah.
He went back to Switzerland. I went with him on a personal note. That was my honeymoon. And my wife on our honeymoon, and I went to the course. She kind of stayed around in the hotel. She always reminds me of that, if you will. But that was back early on.
Yeah.
So we attended that course. Took the advanced course a couple of years later, and I had the pleasure of meeting with Hans Villenegger. Yeah. And I brought with me examples of the cases that we were performing, and he was quite interested. He really had never seen anything of that nature. Certainly ankle fractures he had, but he never really had seen any reconstructed foot surgery being done with screws and plates and things of that nature. So he was very interested. We had some very good discussions, and I was involved with the Podiatry Institute, certainly, and we ran all kinds of courses. And I think it was probably the mid 80s. After attending the AO courses, we designed a fixation course for foot and ankle surgery and ran it through the Podiatry Institute from, I think it's like 1985 through the early 90s. We had it here in Atlanta, and all the equipment was supplied by Synthase. So we were kind of rubbing elbows with AO, but we really weren't AO at that point. And that was a 4-day course. So it was a long, drawn-out thing, and we ran that for quite a number of years. And it was just tremendously popular because that was a new skill that was in our profession at that time. And Synthase was aware of it, and I guess the communication back to AO was that this was a positive thing. And we ultimately established a relationship with AO North America directly, and in the early 90s, and then started the AO Podiatric course in 1993. That was, I think, in Baltimore, Maryland, and at that time, Kieran Mann, recent past chairman at the Temple School, Jack Schubert certainly was very integral, and Chuck Gudis. Always want to remember Chuck as really one of the pioneers. I think Chuck actually did the first official podiatry AO fellowship, where he went over and spent a couple months in Switzerland studying over there. So I'll always remember Chuck as founder of the group, if you will.
That's fantastic. It's neat to kind of hear all the different, sides of how these things have come about, and things that, I think some of myself included, we kind of take for granted that these are technologies that have continued to advance the profession. And
I see, Joe, what I see when I look at the young students, that they think this stuff has always been there.
Yeah, exactly.
It's no big deal. This is just what's there. But obviously there's a history as to how we got here.
Absolutely. And it's really such a wonderful opportunity to hear those stories and hear, we talk a lot about mentorship, and especially at the student level, like how important and how valuable those things can be. And so having an opportunity to hear some of the people that helped kind of shape your career and influence your career. And as you've seen some of this like evolution of our profession, what do you think are the most important accomplishments that have happened?
Well, and I'll keep going back to the internal fixation thing, if that's okay. Again, having had the opportunity to see foot surgery done before internal fixation was a factor. For example, I remember my dad doing a base wedge osteotomy for first metatarsal. And he would use some type of cerclage wire to kind of hold the cortex together. But they'd put the patient into a surgical shoe and let them walk out of the office, basically. And if I were to, I can imagine, I can just see your face, Joe, and she's kind of looking at it. Why would anybody do that? But that's the way it was.
I wouldn't sleep at night.
It would be tough. And obviously the complications that ensued from that were because of an incomplete understanding of the real surgical principles of bone. Yeah. And that's really where the AO changed, to me, the type of surgery that podiatry was doing. We had many talented surgeons, and were innovative in their techniques and application of osteotomy and fusion, things of that nature, to the foot and ankle. But it was very important that we understand the physiology of bone healing and the mechanical aspects of it that make it a success. And that is a major change. That was the major thing that I saw in my career, transitioning from, if you will, the old way to the new way of doing bone surgery. So that really, to me, is the biggest thing from a surgical perspective. Yeah. What else?
Did you have a question, Jeff?
No,
okay.
I've got a bunch of questions, but feel free, carry on.
So if those are some of the main accomplishments, what do you think in the current phase of the profession, what do you think are the biggest challenges that we have ahead of us?
Well, to me, the biggest challenge that I see as I see our young students and residents coming into practice is, I'll use the word 100% commitment to their learning process. And, and again, I hate to say, back when I was a resident, it was 24 hours a day, 7 days a week, 365 days a year. And, you snuck off a weekend here and there, but you really were totally committed to learning as much as you could. Mm-hmm. And today I see students going through school. I see them going through their residency training, and that desire to be accomplished, to be competent, to be know everything they need to know, sometimes I see as a little lacking. And so it's you ask questions and you realize that they don't have the background information that you would want them to have to continue the discussion. And I don't know where that shortcoming is coming from, whether it is the schools, the education that is being delivered at the school, what level it's being given, whether it is just the way people learn these days, and it's a different process. So I'm always eager to engage with that student, with that resident that we always use the word to chew off the end of the table. That they just wanted to get everything they could get. And that's what has always stimulated me to share my education or experience with them, is to see that. And so I look forward to finding those types of people.
Yeah. I think that's one of the most interesting concepts, right? Like, how do you engage passion? How do you teach that? How do you help spark that curiosity in people? Because, everyone comes in with their own skills and talents and abilities to process information, and trying to, as you say, like find that little spark and then help them cultivate it, help them engage with it, know how to ask the right questions, how to be present. And it is an interesting, attention culture, as they call it, the shifts that we've seen in so many different regards, but definitely in the attention world, I think is a major challenge. And I know certainly for us in the academic world,
Right.
finding ways to connect with them in ways that are meaningful, in the ways that they do develop and retain content. And I think that was one of Jeff's main intentions in creating a podcast, is as you ask some of our younger learners, like, they don't really want to read a book about something, right? Like they would much rather, and in fairness, they don't really have the time, right? Like, everyone now, they're overscheduled and not in a way that is beneficial. So I think finding creative options to facilitate this re-engagement in passion is the next big adventure, if you will, in education.
It is. Yeah, because it's the level of capability. It's so important. And these young people are going to be going out into practice and taking care of me and my children, my grandchildren, and I want them to be as skilled as they possibly can be.
Yeah.
Absolutely. John, I had a thought on that. Even 30 years ago, the pyramid was so steep with top programs. The competition to go to Doctors or Pittsburgh or Highlands or Kern was so intense, right? Now, thanks to the training that many, many doctors have gotten, in Atlanta and around the country, there's so many more residency programs, and there's lots of opportunity for the students. And I think while we can look back and say, oh, it's not quite like it used to be, I mean, it is incredible how many outstanding training opportunities are available today for our students, thanks to people like you that have given back for so many years to the profession.
Well, there's, again, when I was out there was 1 3-year residency, and now they're all 3-year residencies,
right.
As you say.
Right. And when I got out, I got out in 91, I guess, I think there were 550 graduates. That seems to be pretty standard, every year, even to this day. I think there were 88 2-year surgical programs and just a couple of 3-year programs back then. So, I mean, it's really neat to see the profession grow, and it's really neat to see so many great doctors that are willing to take the helm as a residency director and attending around the country. But again, that family tree, as they say, a lot of it starts at doctors in Atlanta.
Yeah. There's been, we've got a plaque on the wall at the Institute, and we have a little over 150 graduates now from the program over the last 50 plus years. And it's really interesting to go through it and see the past chairman of surgery departments at the schools and directors of these residency programs and presidents of FACFAS and all of the different individuals that have gone through our doors, if you will.
Well, yeah, and driving the profession forward, no doubt.
Great people.
So when you're not doing podiatry, what are some of the things that fill your cup?
Well, that's my problem, Joe.
Well, I do see some photos on the back of your wall.
Yeah,
that probably take up some of your time.
That probably is true. My very dear grandchildren. So unfortunately, they all live in the area, and I do have the opportunity to be with them quite frequently, or the moms and dads dump them off at our house, one or the other, and so we get to see them. My oldest son he's 43, and he's an attorney here in town, and he lived in Japan. He's been a martial arts student for his entire life, and I don't know if you're familiar with kendo, but that's the Japanese samurai sword training process, and so I try to participate in that with him, and my granddaughter and my grandson are both involved. So it's a good way to get a little exercise and continue, if you will, a family tradition in that context.
That's outstanding. Yeah.
Pretty neat. I have a pellet grill, so I'm a griller. I probably cook myself my dinner almost every night, and enjoy doing that, especially for the holidays and things of that nature for the family, big groups, if you will. So I do a little bit of cooking.
That's great.
That's outstanding. So if you weren't a podiatrist, what do you think you'd be, John?
I think I can answer that. I think I would have been drawn into plastic surgery.
Really?
I was always along with the bone work, if you will, but I can remember I had the opportunity to work with some plastic surgeons while I was in my residency training, and then after, and I was always intrigued with the finesse and the skill, and I basically have tried to carry that into the dissection process that we do as far as our training is concerned. And so this concept of anatomic dissection, if you will, that the Institute has been known for over the years is very important. And I take that really, while the bone work is very important, personally, I feel that my role in training our residents is to teach them how to dissect, if you will, how to surgically open and identify and work with and repair and close the soft tissues around the bone structure. I think that is obviously every bit as important as the bone work that we do, but it can make or break the surgical procedure most definitely. So dissection is, if I would say, is my passion, and bone work is right there side by side.
Excellent. I had no idea. People ask me that question sometimes when they ask questions, and I'm not so sure. I think I would have enjoyed law in some regard, like patent law or something. But that's cool that it makes sense too, with your background in dissection and all that would fit the bill. I can see that. Joe?
So as we kind of target some of our audience toward prospective students, what kind of advice would you give someone who, let's say, is in their second year of college, trying to decide, they're wanting to do something in the health professions, they're thinking med school? What would you say are some of the pieces of advice that you think are useful for them?
Well, I think the best way is to identify a really good podiatrist in the area that you're living and spend time with them. We have that in our office quite frequently. We have various universities in the Atlanta area, Emory and UGA and Georgia Tech, and we constantly have college students come and spend time with us, and we'll see them over a year, 2 years, or longer. They'll come visit and spend a day here and there. Excuse me. And it's so exciting to see them then go and enroll in podiatry school and move on to their residencies and follow their careers as well. So I think that's an easy answer. Go find a good one and spend time with them and try to learn what's being done. Absolutely.
Yeah, we talk a lot about the shadowing opportunities and how it's been interesting as I've listened to Jeff interview multiple different people on the podcast, and, how people find podiatry. And it's like the best kept secret, like how do we not know about it? And most people, the thing that really kind of helped the most was shadowing. And it's relatively simple. COVID threw a little bit of a monkey wrench in there, that it was harder for students to find shadow opportunities. But the idea too, when you said, find a good one, shadow a bunch of different offices, because you never really know, everyone has their subspecialty even, some people are just more sports med, some are more reconstructive, some are more wound care based. So having a variety of opportunities can be useful too.
Absolutely.
Yeah.
Absolutely.
John, I have a question for you. A hot topic in the profession right now is fellowship training.
Yeah.
And I'd love your opinion on fellowship training. As these students, they go into residency, they're already doing 3 years. I guess there's two camps. One is like, get as much training as you can, absolutely. And the other is, after 3 years, if you did a great program, you get a great opportunity, jump on it. What are your thoughts?
Well, I think all those things are correct. While you're in your 3 years of residency, you want to get as much exposure and training as you can. And I think that it's not unreasonable. Not all residencies are equal. Mm-hmm. And so some programs are going to have much more surgery, much more involved surgery, trauma, all types of advanced surgical experience. But not all programs have that. So if you have a program that doesn't have that advanced level of training, then if you have the desire to attain those skills, then a fellowship would be very valuable for you. If you have a great program and you have experience from A to Z, and you are comfortable, then I don't know that a fellowship is necessary for you. And where I would then open the door for fellowship, even for that individual, is if they have a unique desire. I want to do trauma. I want to do limb salvage. Whatever the more advanced skill process is, if you have a passion for external fixation, that's where fellowship training is critical. And it's very important. So it's not for everyone. I don't think every student has to pursue 4 years. There are some that need it, and that would be beneficial for them. And other people, it is necessary for them to pursue that path. Because you just can't go open a practice in Paducah, Kentucky, and practice limb lengthening, if you will. It doesn't work that way. You've got to get into the field and the flow, and find an environment where you can do what you want to do.
It's interesting. You mentioned competence or confidence. They kind of go hand in hand. The docs I've talked to that have done fellowships have commented that they really appreciated the fact that they were the only one there in training. And that not only could they do the surgeries, but they were very much involved with the workup and the follow-up. And if you did that intensely for a year, it vaults your clinical career ahead.
Oh, totally.
And that makes sense. Yeah, I'm with you on all of those. And I know our students all the time, they're coming back and, they're right away in their second year of residency, they're already planning, right? And they're coming back and asking us, what do you think? I've got this opportunity, that opportunity. And we didn't have this many fellowships just 10 years ago.
No. It's very, very exciting to see that available to us. And, I think it creates such a wider scope of practice in our profession. And the more, the better.
Mm-hmm. That's how I look at it, too. Well said. Joe, any other questions for you?
I think we've hit on all the high points that I really wanted to make sure that we covered. I guess the other question that I would have for you, Dr. Ruch, is let's shift focus to maybe not right out of residency, but maybe that 2 years out of residency. So you've been out long enough that you're kind of getting your grip on what it's like to be a practitioner. What would your advice be for career planning, career trajectory, right? Like any advice for that hump where it's like, where do I want to go from here? What are your thoughts on opportunities?
When I talk to my residents, today's modern practice is so much different than what it was when I left school. So today you've got, you can go into practice with an orthopedic group and you can become the foot and ankle specialist for that. You can go into a multidisciplinary group. You can go into a mega group where you got 500 podiatrists are in the group kind of thing, and it's working in the business of medicine. And I guess for many of our graduates, that's all they know, so they don't know any different. Whereas if you finish your training and you go practice in a small town in South Georgia someplace and you're solo practice, that's a totally different type of practice experience, and it takes a whole lot additional skills to be able to do that because you have to manage the process. So you have to be aware that there's more than one side of practicing. Mm-hmm. And you don't necessarily know what is going to be best for you. You may have an idea, and that's great. And if it is, pursue it and do it. But so many people finish their residency and they say, well, what do I do now? And that can be a big dilemma or challenge. So I do tell my graduates, make the best choice you can. Mm-hmm. It's not forever. And there's experience to be had. So I would say definitely consider that first few years after your graduation as just an extension of your training, if you will. Identify the aspects, the medical management processes, the business processes, and see how that fits into your perception of what you do for a living. And for some people, working for the company is just fine, and it handles a lot of problems and makes things very easy, going in and making your numbers, if you will. Mm-hmm. There are some obviously limitations with that type of practice. Going in, I don't know, Joe, I don't know how anybody can go into solo practice today, but I see people do it.
Yeah.
They've got to be very unique, very strong people. I'm always impressed when I see somebody do that. So it can be done. But you kind of got to walk through the weeds and figure out what's going to work for you. So your education doesn't stop when you finish your program. There's a whole other facet of our profession and medicine and practice in general that you have to figure out.
Yeah. I think sometimes too, those are definitely the things, we're not taught that stuff in school, right? Oh, and how do you conceptually prepare for the unknowns, right?
Right.
And to your point, you don't really know what practice type maybe suits you best. And so I loved your story when you were talking that you had gone back and you'd worked with your dad, and then you realized, hey, there's a part of me that I love teaching. I'm not really able to do that here. So I'm going to make a change. And I think that's the part that's sometimes hard is you don't know what's going to happen with the change. And so being willing to be flexible and adaptable, and if something's not working, make a change.
Absolutely.
Yeah.
Absolutely.
John, I'd be remiss if I didn't ask you this question. Coming from California, I interview a lot of docs that are surgeons, and they're not quite as high profile as you are. But I thought it was interesting in your bio that you mentioned your mentors were Dr. Weed, Dr. Root, Dr. Orion, and that biomechanics background. And then you took that knowledge and took it to surgery. Can you elaborate on that a little bit? Because there's a lot of people talking about our students are missing the biomechanics and foot function aspect of surgery.
I go back to my biomechanics education. And while I was a student, I was very active with them and helped a lot in, I don't know if you remember the compendium, that orange and white text.
Yes.
And I did a lot of work and research to support these guys as they wrote that. And I learned a lot about anatomy, foot function, motion of the foot and ankle, lower extremity, et cetera. And I always tell my I like to take our students and residents that are new to their exposure to me, and I ask them, show me how the subtalar joint moves. And they take the heel in their hand and they invert the heel and they evert the heel in the frontal plane. And I say to them, is that the motion of the subtalar joint? And they said, yeah. And I said, well, no, it's not. and then I try to show them how that joint really moves. And, I don't know whether they believe me or not, but all of a sudden their knowledge of biomechanics is being put into question. That's not what biomechanics is. And I don't care whether it's a forefoot varus or a forefoot valgus or, 2-degree post here or there. That's what people perceive biomechanics to be. But for me, it became the ability to assess the anatomy, understand the motion of all the joints, to be able to determine normal motion versus abnormal motion, and then draw upon that all the other structures that influence it, from the muscles in the leg to the hip position and knee function, et cetera. All these different aspects that impact how that foot aligns and moves. And in evaluating, somebody will call me, I want to refer you a patient, John, and we all try to have a language that we can communicate, but until I can put that physical foot in my hand and assess the motion, position, alignment, function, that to me is what biomechanics really is, as far as a surgical perspective. Now, if you're working on orthotics and you want to use this post, that's fine. That's appropriate, and I understand that. But for me, it goes much beyond that for the surgical application.
Absolutely. No, I think I'm going to take this little segment, John, of this interview, and I'm going to play it in our biomechanics course at the beginning. Okay. And because we always tell the students, and you alluded to it also, anatomy is everything, right? If you know your anatomy, then you can start to put the foot together and understand normal and abnormal function of the foot, and then that carries over to surgery. So thank you for that explanation. I thought that was excellent.
Good.
So John, I have a question for you. Do you think your father would be willing to join us on another episode?
I think that he would be honored. Really? The problem is he can't hear over the flip, and so I think physically it might be a problem for him. I would be happy to broach the subject with him.
Okay.
And if he felt like he could do that, I'll tell you what, he's coming down to visit me during this upcoming year, and we could do it together. I could make arrangements to get headsets for him, and he wouldn't be able to handle the computer stuff, that kind of thing. Not that I can do it very well either, but I can see if he would be excited to do that. I'll let you know.
That would be so incredible. The stories of graduating in 1950 and doing the civic hospital experience. Sure. And I just think that would just be one of the neatest episodes we could possibly do. So thank you. That would be really fun. Joe, do you have any other questions for right now?
No, I'm so grateful for the time that you've given us today, and it's been wonderful to hear all your insights and perspectives.
Thank you so much.
Absolutely. Thank you, John. And John, we're going to be sending you one of these Dean's Chat cups.
Wow. All right.
A lot of our...
For your porch.
Yeah. I've noticed that a lot of our guests take their coffee or tea very seriously. And I don't know if you do or not, but this will add to
absolutely.
it.
Absolutely.
All right. Sounds good. And so thank you again. We are so thankful that you shared your experience with us today with all of our audience. And to our audience, if you are listening on Spotify or Apple Podcasts, please give us a 5-star rating. And if you're on YouTube, please become a subscriber. John, thanks again. And until we talk again, cheers, everybody.
Thank you so much, Jeff. Appreciate you having me. And Joe, I'm so honored that you would ask me, and thank you so much.